Hello, friends.
Now for a big topic on exams, depression. Also called MDD, Major Depressive Disorder, which is also called clinical depression. Clients experience a severely depressed mood, loss of enjoyment in life, low energy, and just feel like blah. Everything is low and slow, kind of like Eeyore from Winnie the Pooh. Everything is just super slow, low energy, and a very, very sad mood. It's thought to be caused from the low levels of happy brain chemicals, those neurotransmitters. So low serotonin, low dopamine, and low norepinephrine. Now the cause of depression is unknown, but the risk factors play a big part. So in terms of risk factors, stressful life event like a trauma, a death in a loved one, or even a recent job loss, all can add stress. Next is a chronic illness that is debilitating, for example, Parkinson's disease. And even genetics plays a big role, so a family history of depression will usually be passed on to the kids. And females have it more commonly than males. And very lastly, substance abuse plays a big role as well, like abusing alcohol or drugs. So ATI mentions a risk factor for depression, stressful life events. And Kaplan mentions, a client recently becomes unemployed and the client reports feeling depressed. The nurse understands which statement to be true. Unemployment is a significant potential stressor. Now in terms of signs and symptoms, as well as diagnosis, 5 or more of the following symptoms consistently for 2 weeks are seen in order to make an official diagnosis of MDD. Again, think of Eeyore from Winnie the Pooh. Low and slow energy, mood, and even slow movement. So number 1 is a depressed mood. Clients feel hopeless and empty. Number 2 is anhedonia, as mentioned by Hesse and ATI. So write this down. Loss of joy and interest in life. Number 3 is weight loss, typically anorexia, but we can also see weight gain. But really, it's more common for a loss of appetite and rapid weight loss. Now, number 4 is a big NCLEX tip here. Psychomotor retardation. So write these down. Slower speech, response time, and decreased movement. Clients will often respond slowly to yes and no questions. So again, think of Eeyore from Winnie the Pooh, very slow response times. Number 5 is insomnia, or even hypersomnia, sleeping too much. And number 6 is fatigue, also called anergia. Like a blanket of heavy fatigue, clients will not be able to move from their bed for like 3 days or more. And they won't eat or shower or groom because of all this fatigue. Number 7 is feelings of worthlessness or even guilt. And number 8 is difficulty concentrating. And lastly, a big one is suicidal thoughts that are reoccurrent for number 9. So be sure to pause your screen and really focus on the bolded ones here, since these are the most tested. Now Hesse had 2 questions on this. So the client states, life just doesn't have any joy in it anymore. Things I did for pleasure aren't fun. Anhedonia, the loss of pleasure in life. And question 2, which complaint regarding sleep would the nurse expect from a client diagnosed with major depression? I wake up at 4 a.m. and cannot go back to sleep, and I feel tired all the time. And ATI mentions, a nurse is assessing an adolescent who has depression. Which of the following findings should the nurse expect? Select all that apply. Irritability, anergia, or fatigue really, anhedonia, that loss of pleasure, and appetite changes. Now a little side note for adolescents. So adolescents between 10 and the teen years, all the way up to 19, huge NCLEX tips. And be sure to write this down. They typically present with angry or aggressive outbursts, as well as vandalism and even skipping class. And weight loss or weight gain, that is sudden or rapid, as well as napping during the day or excessive sleepiness during the day. And lastly, a big one here is low self-esteem, known as withdrawal, especially from activities that they once loved or were good at. So let's say a cheerleader captain suddenly quits everything and is now a loner at school. Huge indication of depression. So a top missed NCLEX question here. Which of the following pediatric clients should the nurse screen for depression? Select all that apply. A 10-year-old who's taking frequent naps during class time. Yes, the key term there is frequent naps. A 16-year-old who quit the chess team despite being the team captain. Yes, withdrawing from things they were once good at or used to enjoy. Now, a 14-year-old sent home from school due to angry outbursts and skipping class. Yes. Remember, angry outbursts, skipping class, and even vandalism are big key signs. And a 17-year-old who suddenly lost 15 pounds in 4 weeks. Yes, once again, rapid weight loss. Now, for the types of depression, we see dysthymia, which is a long-term persistent depression. We see mild symptoms for about 2 years or more. Seasonal affect disorder happens in the winter due to the lack of vitamin D from the sun, and it's usually treated by the use of light therapy. So Hesse mentions, seasonal affect disorder, what appropriate action? Instruct the patient to be exposed to a light source for 30 to 45 minutes daily. And lastly, a big one here is pre- and postpartum baby blues. This occurs either during pregnancy or 4 weeks after pregnancy. And it's thought to be from hormonal and even lifestyle changes. But we cover this in our full video in the maternity course. Now, in terms of treatments, let's do a rapid overview, then we'll break these down one by one. So there are 3 phases of MDD treatment. Phase 1 is the acute phase. We see severe clinical signs in 6 to 8 weeks, and suicide risk is very high. Now, the goal in this phase 1 is to have remission of symptoms and restore the function with antidepressant medications, psychotherapy, and even ECT, which we'll cover in a moment. Now, phase 2 is the continuation phase, increased ability to function, and the goal here is to prevent relapse. And number 3 is the maintenance phase, over 6 to 12 months. The goal is to prevent reoccurrence, and we want the client to return to normal functioning. Now, in terms of nursing care, the big priority is for suicide risk. Now, the assessments, the key signs to watch for is number 1, a calmer and more energetic client. This means increased risk for suicide or increased suicide risk. So watch for words like sudden, abrupt, or rapid change in energy. So write down these key words. Any sudden or abrupt, rapid change in energy levels typically means a client is more suicidal, with more energy to actually do the suicide. Especially true after starting antidepressants like SSRIs. Clients have more energy to actually follow through with the suicide. So ATI mentions major depression and suicidal ideation, who is suddenly calmer and more energetic. Which of the following should the nurse consider? The client is suicidal. And Saunders, a depressed client suddenly begins smiling and reporting the crisis is over. The client says to the nurse, "I'm finally cured." The key intervention is increasing the level of suicide precautions, so be sure to write those down. And another key assessment to watch for is the client starts giving away possessions that are cherished and valued. And look for statements like, "I can't go on," or "I don't want to live." So, "I won't be a problem much longer," as stated by Hesse. And "this will all be over soon," as stated by Kaplan. So when we hear these certain statements by the client, we must ask certain questions for suicide risk assessment. For example, have you had any thoughts of hurting yourself? Huge NCLEX tip. This one always shows up. Or, do you have a plan to kill yourself? Or, do you want to die? The questions should be direct and very blunt, not open-ended. So very straightforward questions. So Hesse mentions, a man tells the nurse he has no reason to continue living. What should the nurse ask him first? Do you have any plans to end your life right now? And Saunders, which behavior indicates an adolescent client may be suicidal? The client gives away a DVD, and a cherished autographed picture of their favorite performer. Yes, giving away cherished items is a huge indicator. Now for the big NCLEX tips, if the client has a plan to harm themselves. Number 1, we do continuous one-on-one observation with the client. Now this is the number 1 priority to ensure safety. They will be on a 72-hour hold and suicide watch. Number 2 is a semi-private room near the nurse's station, not a private room. This decreases isolation and allows rapid access to the client. So write this down. We always remove harmful objects from the room. For example, sharp items or even belts, ties, and glass. And inspect the client's personal belongings. Number 2 is we supervise the client during meals and always reassess any changes in suicidal thoughts. A goal statement that we're looking for that shows a client is not currently at risk for suicide is, write this down, clear plans of the future involving personal goals for family and friends. Big NCLEX tip. So be sure to write that down. So Kaplan mentions, a client states, I don't want to live anymore. I'll find something else to kill myself with. Which nursing intervention is important to perform next? Provide direct one-on-one observation to the client at all times. And Hesse has 2 questions. A client admits to a plan for suicide. What is the nurse's priority action? Provide one-on-one supervision. And a second question. 1 week ago, a patient attempted suicide. Which comment by the nurse is most therapeutic? I'd like to hear about how you are feeling now. Yes, always reassess. Now, in terms of interventions for depressed clients, just in general, the goal here is to feel better and less depressed. So, encourage and invite the client to participate in their own treatment plan and also in activities. So, Kaplan mentions the client diagnosed with depression, which approach by the nurse is best. Invite the client to join in group activities. And Saunders, a client with a diagnosis of depression, plan of care that includes which intervention? A structured program of activities in which the client can participate. Next is assist with ADLs. These clients experience severe fatigue and lack of motivation. So a big NCLEX tip here is help the client get ready, especially when they have not left the room for a few days. So help them get out of the room and go to the unit and even go to the dining hall or commons room. Next, we always spend time with the client. A big key term here is to sit with the client and communicate with simple and direct language. So Kaplan mentions, the client is crying alone in the room. The client has refused to eat breakfast or have morning care. Which intervention by the nurse is best? Offer to sit with the client and help the client get dressed. And ATI had 2 questions here. A newly admitted client who has severe depression. Sit with the client and offer simple, direct information. And a second question, the client seems more withdrawn and depressed than usual. Say to the client, I would like to spend some time with you. And very lastly is re-evaluation. Is the client getting better for discharge? We want the client to have less symptoms and more energy and even more interest in life itself. So Hesse and ATI mention this in various ways. Hesse talks about which comment shows improvement in depression. I talk with my family about ways we can celebrate the holidays together. And ATI, which of the following behaviors indicates a readiness for discharge? Verbalization of feeling in control of self and situations. Now switching gears to diet. Remember, the big symptom of depression is rapid weight loss or weight gain. But typically weight loss is most tested since it's most common. So clients lose appetite and refuse to eat. So for poor nutritional intake, write down these 4 key points. Number 1, we provide small, frequent meals. Number 2 is high-calorie foods and fluids. And 3, stay with the client during meals so that they finish all their meal. And number 4 is we always use weekly weights to track progress. So Saunders talks about a client with depression who has poor nutritional intake. Which intervention in the plan of care? Select all that apply. Assist the client in selecting foods from the food menu. Offer high-calorie fluids throughout the day and evening, and offer small, high-calorie, high-protein snacks during the day and evening. Yes, always those small frequent meals that are high in calories. And HESI, imbalanced nutrition less than body requirements with severe depression. The most reliable evaluation of the outcomes. Weekly weights. Yes, we always track weights to monitor progress. Now for therapeutic communication, always the most trickiest questions on exams and the NCLEX. So let's play a quick little segment from our full video on therapeutic communication. Therapeutic communication is our next topic. This is defined as a face-to-face process of interacting with clients and their family members that allows them to express their own thoughts and feelings in order to build trust. Now, textbooks will always recommend open-ended questions and close-ended comments. So open-ended questions are those questions that are not simply yes or no questions. They instead require a response that is not simply yes or no. So this promotes discussion with the patient. Now, closed-ended comments are like stating facts that are used to portray empathy and build trust, as well as assess further. So HESI mentions open-ended questions. Select all that apply. How do you cope with anxiety? What event in your life has been the most stressful? Can you please tell me more about what's happening to you that led you to be hospitalized here? So as you can see, all these questions are not simply yes or no answers. They require the patient to converse with the staff. So let me show you how this works. For example, say a client presents to the hospital after a suicide attempt. As you can imagine, the family and the patient will be emotionally in turmoil. So remember, the goal here is to, number one, build trust. So the 2 NCLEX tips to write down is number 1, ask and assess emotions. This is done to obtain important information. So for example, tell me when you started noticing, or tell me what concerns you have. What are you feeling right now? How are you feeling about your baby? So using these broad, open-ended questions will help uncover and assess important information, which will help decision making. Now, number 2, our second NCLEX tip, is always state the facts to build trust and reflect on how the patient feels. So for example, we have the vital signs under control. This helps to build trust with worried family members. Or, you must be very upset after experiencing this. Or, I understand you are worried. This portrays empathy. All we're trying to do is state the facts that's going on. For example, you sound very discouraged and scared. Or, you sound angry. Anger is a normal feeling associated with loss. Or it can be a combo effect, which we saw a lot on our NCLEX review. For example, this experience has been very overwhelming for you. What are you feeling right now? So you can see how the facts are stated and a question is asked, but it's open-ended, not a simple yes or no. And another example here. Clients with cancer experience fear of dying. Tell me about your concerns. So you can see, we ask and assess emotions and we state the facts. Now the big things to avoid here, the non-therapeutic communication. So, huge NCLEX tips. Do not offer opinions or advice, or even personal experiences. For example, never say, I know how you feel, or I too had a miscarriage, or even, I also had breast cancer. The second thing we don't do is minimize the client's feelings. Remember, we want to show empathy. We just don't want to make the feelings smaller. Number 3 is we never leave the room. No. Never leave the room. Always stay with the client to show support, even use therapeutic touch to show empathy. And a huge one right here. Never give false reassurance. Huge NCLEX tip. So write this down. Never say everything's going to be all right, because you don't know that. And never say, I'm sure you will do the correct thing. Remember, never do this. This does not build trust by assessing emotions, and it doesn't state any facts. It simply applies an opinion with no certainty. So stay away from opinions. Now, another thing to stay away from is never ask why. Another big NCLEX tip. Well, why though? Well, why questions are always avoided on the NCLEX, since clients typically view this as judgmental questions or even intrusive speech, which destroys not only the nurse and client trust relationship, but it results in the client getting very defensive. So never ask why. For example, why do you feel angry when? Or why do you act this way? Or even, why did you leave your child alone? So remember, never ask why. Now, a top Miss NCLEX question here. An elderly client loses their spouse to pancreatic cancer. Choose the most therapeutic response. Select all that apply. Okay, now before looking at the options, remember to ask questions and state the facts. Those two things. Always assess and then state the facts. So option 1, leave the room to allow the client to grieve in private. No, always stay with the client to show support. So watch out for the key term, leave the room. We never leave the room. Stay with the client. Now option 2, the nurse states, I recently lost my grandfather to cancer, so I understand what you're going through. Now, this one is tricky, but it's technically wrong. Do not give your own personal experiences. This diminishes the client's emotions, so don't get tricked. Now, option 3, I know this is a difficult time for you, which it is, that's a fact, yes. Tell me how you've been coping with this. Yes, you stated facts and you asked questions. This is therapeutic communication. Now, option 4, what are your feelings and thoughts about attending a support group? Yes, we're asking questions and we're offering recommendations here. Now, option 5, it takes time to heal with and come to terms with a lost spouse. But it will be okay. Man, so close, but so far. Now, the question or the option started correct. It takes time to heal and comes to terms with a lost spouse. That is true. That's a fact. But it will be okay is false reassurance. So this is incorrect. And the last option here, option 6, why do you feel sad? No asking why. So just throw that question out. Anytime you see the question or even the option why, just toss it out. Okay, now we're going to go over a lot more examples, but first a little side note here for your nursing exams to clarify some various terms and techniques of therapeutic communication. So asking questions helps to explore emotions and gather more information. This encourages the client to discuss relevant events and even feelings. Restating is repeating the patient's words to confirm what you understand. And reflecting returns focus on the client. Now, the second thing, we talked about stating facts, voicing doubt and presenting reality. This refutes misconceptions or even delusions without confronting the client's beliefs, especially true when communicating with schizophrenic patients, which we have a few examples in a moment. And lastly, suggesting resources or strategies helps to offer guidance. For example, recommending that support group, like in our question before. Now, I wouldn't focus on these terms too much or get hung up on the memorizing them, since exams and the NCLEX will have questions directly on responses and not technically on terminology. So let's give a few practice questions from the top tested textbooks here. So Hesse mentions, what is the most helpful nursing response to a patient who reports thinking of dropping out of college because it's too stressful? Well, school is stressful. Yes, you stated the facts. What do you find most stressful? Cool, asking a question. We got our 2 items there. Now, question 2, which statements will the nurse indicate as therapeutic? Select all that apply. Am I correct in restating that you are feeling less anxious today? Yes, that is pretty much restating. That's the key term there. You're stating the facts and restating what the question or what the client has just said. In looking back at what you said, you stated you are feeling better. Yes, that is restating. Help me understand what you're feeling today. Yes, we're assessing the client. So remember those two items. State the facts and ask questions. And question 3. A man was killed during a robbery 10 days ago. His widow cries spontaneously when talking to the nurse. What is the most therapeutic response? The sudden death of your husband is hard to accept. Yeah, that's a fact. Tell me about how you are feeling. Yes, that's a question. So stating the facts and asking questions. So Kaplan mentions a client with end-stage heart failure says, why can't this just end? I'm no good to anyone anymore. Which response is best? This must be difficult. Stating the facts, please tell me about your feelings. Cool, open-ended questions there. And question 2, the nurse finds the client crying and says, what do you want? Go away, you can't help me, I hate you, and I hate myself. It sounds like yourself after a failed exam, huh? Well, which response by the nurse is best? You seem to be in pain. State the facts. I'll stay with you for a while. Now, this is really tricky, right? Because the client just said, go away. But really the correct option is to always stay with the client. Now, question 3. The client's spouse has been unemployed for 6 months and is afraid of not being able to pay the rent. Which response is most appropriate? You're worried that you won't be able to pay the rent? Well, yes, you're stating the facts and we're also restating the problem. Now, ATI mentions, I am really concerned about my mom. Which of the following responses should the nurse make? Tell me what is troubling you. Yes, you're drawing information out of the patient. The second option is tell me about what you're feeling right now. What is upsetting you? Yes, always assess and never ask why it's upsetting you. And lastly, it seems you feel responsible for what happened to your mother. Yes, stating the facts. Now, question 2, the client who has cancer is scheduled to receive chemotherapy. She wants to try homeopathic treatments first. Which of the following responses should the nurse make? Tell me more about your concerns about taking chemotherapy. Yes, we're having the patient open up to us and we're assessing emotions. And lastly, question 3. A parent who recently lost her child states she cries frequently and can't bear the loss. Which therapeutic statements should the nurse make? You are feeling great pain at the loss of your child. Yes, stating the facts. Now you can see how easy these tricky questions can be. Always ask questions and state the facts. Now lastly, Saunders had a lot to say as well. So let's practice these. I can't believe my wife died yesterday. I keep expecting to see her everywhere I go in this house. Therapeutic nurse response. It must be hard to accept that she passed away. Yes, state the facts. Now question 2, this condition is just another nail in my coffin. Which response by the nurse is therapeutic? You seem very distressed over learning you have asthma. So yes, once again, state the facts. And lastly, question 3, a client diagnosed with terminal cancer says to the nurse, I wish my family would stop hoping for a cure. I get so angry when they carry on like this. Which response by the nurse is most therapeutic? You feel angry that your family continues to hope for you to be cured. Yes, we're stating the facts and we're restating what the patient just said. Okay, if that's not enough practice for you, then watch this next segment from our schizophrenia video. Now, switching gears to therapeutic communication. This is always the most tricky questions on exams and even the NCLEX. Now, we have a full video on therapeutic communication in our mastery course, but let's deep dive specifically for our schizophrenic patients. So first things first, assessment. We always ask open-ended questions, especially when clients are having delusions that people are trying to hurt them. So open-ended questions are basically any question that doesn't end with a yes or no answer. So for example, what are the voices saying to you and what do you see? This actually was an NCLEX question, so I'd write this one down. You see how this question is open-ended. It doesn't end with a yes or no answer. It deeps dive into a deep assessment. So Hesse mentions, tell me what you're feeling at this moment. Describe what you are seeing now. You see how deep we're going into this assessment. And Kaplan mentions, how does it feel to think you are being watched? And ATI, what activities did you enjoy in the past? See how each question is an assessment. So to help you put into more context for an exam question, let's do a Kaplan full question. Do you see those cameras in the ceiling? I'm being watched all the time. Which response by the nurse is most appropriate? Those are the sprinklers in the ceiling that come on if there's a fire. How does it feel to think you are being watched? Yes, this presents reality and acknowledges feelings. Next, we always state the facts. To build trust, we present reality. And to show you acknowledge the client's feelings. Huge. So, for example, I see you're frightened. Let's go to your room and talk about this. Huge NCLEX tip. This actually came up on a few questions during our NCLEX review. Now, Saunders mentions, it might be frightening to think that others want to hurt you. So, we are acknowledging the client's feelings. And Kaplan, I don't hear any voices, but I know they are scary for you. So yes, this states the facts and acknowledges the client's feelings. And Hesse, I understand the voices are real to you, but I do not hear them. Or you see yourself as the savior. I see you as my client. Now, as you can see, all these statements state the facts and acknowledge the client's feelings. So to help you a little bit further, let's see all these statements in action here. Hesse mentions, a client with paranoid schizophrenia refuses food, stating the voices are saying the food is contaminated and deadly. A therapeutic response for the nurse would be, I understand that the voices are real to you, but I do not hear them. And a Kaplan question. There are really strange people in the corner of my room laughing at me and saying horrible things. Which response by the nurse is best? I don't hear any voices, but I know it's frightening to you. Now, in terms of procedures, the top 3 to know for your exams and the NCLEX. Number 1 is ECT, electroconvulsive therapy. Now, this one is the most tested. This shocks the brain and induces a seizure. It sort of kind of jump-starts the brain like jump-starting a car, which we'll break down in more detail in a moment. Number 2 is TMS, transcranial magnetic stimulation, where electric current is passed through the brain, but it does not cause a seizure like ECT. And number 3 is vagus nerve stimulation. It's a surgical implanted device that increases the levels of neurotransmitters, serotonin, dopamine, and norepinephrine. Both are used to treat resistant depression that is resistant to drug therapy. Now let's break down in more detail the most commonly tested ECT. Again, this induces electrical activity on the scalp to create a generalized seizure. So once again, think of this as jump-starting the brain, sort of like jump-starting a car, or even like doing a hard reset on your iPhone. In the same way, it jolts the brain back to activity in hopes of bumping the client out of depression. Each seizure lasts around 15 to 20 seconds and proven to treat clinical depression, schizophrenia, and even bipolar. Now, it's typically done around 2 to 3 times a week for around 6 to 12 treatments. Now, before we do the ECT, there are some key points that we screen for. So number 1, screen for a medical history and report to the HCP these key terms. Any recent myocardial infarction, or basically that heart attack, as mentioned by Saunders, and even any cerebral neoplasm, fancy words for a brain mass, as mentioned by ATI. And we always assess for concerns. Huge NCLEX tip right here. What are your concerns about ECT? So be sure to write that down. Clients typically have a lot of questions when you tell them they're going to have seizures. Next is NPO, around 6 to 8 hours prior to the exam. Huge NCLEX tip. No food and no water. The worst case scenario is the client vomits during the procedure when we give him a seizure and ends up choking, causing a big airway risk. Next is no anticonvulsive medications, another big NCLEX tip. We stop any anticonvulsant medications even if prescribed. So write this down. No valproic acid and no carbamazepine. So remember, we're trying to induce a seizure and we're not trying to block the seizure with this anticonvulsant medication. And we always remove dentures and contacts. And a big side effect to write down is memory loss, as mentioned by ATI and Kaplan. So ATI mentions, which of the following is a side effect of ECT? Memory loss. And Kaplan, after ECT, it is most important for the nurse to take which action? Remind the client that memory loss is temporary. Now, in terms of equipment, we place the client on the cardiac monitor, have a crash cart next to the bed, and always have oxygen and suction ready. And very lastly, last but not least, informed consent must be signed, indicating the client understands the procedure. Now, Hesse mentions ECT. Which equipment should the nurse make sure is available? Select all that apply. So oxygen, suction equipment, and a crash cart. And Saunders, ECT, interventions before procedure. Have the client void, obtain an informed consent, remove dentures and contact lenses, and withhold food and fluids for 6 hours. Now, after the procedure, be sure to write this down. There's no driving during the course of ECT treatment. Huge NCLEX tip. This is because we give sedating drugs, which can impair the client's driving. And lastly, as mentioned before, temporary confusion and memory loss are common after the procedures, as the clients are in the semi-postictal phase from the multiple seizures. Now, in terms of pharmacology, which is always an NCLEX and exam favorite, here are all the key points from all the major antidepressants in this next 18-minute segment from our pharmacology mastery course. Now, antidepressants, the big mamas here. We have SSRIs, SNRIs, TCAs, and MAOIs. Now, we'll be covering these one by one, but first, let's cover the 4 rules to antidepressants. Since the NCLEX will not test you directly on the mode of action, or basically how the drug works, rather it tests safety on how the drug will harm or kill the patient. So guys, we'll be focusing on the need to know for the NCLEX, not just the nice to knows. So these 4 universal principles are NCLEX patient safety. Number 1, increased risk of suicide. As antidepressants elevate the mood, it gives the patients more energy to go out and carry out the suicide. So a big thing to write down is that antidepressants can actually increase suicidal thoughts in the first few weeks of treatment. And the big risk is for young adults, 18 to 24 years old. So we always, key term here, notify the provider of any suicidal thoughts and always clarify any new prescription. Guys, we're monitoring the clients for keywords: new thoughts of suicide, unusual behavior, worsening depression, or sudden changes in mood. These patients are the most at risk for suicide. Now, number 2 is the slow onset and the slow taper off. Never stop abruptly. They're taken for a few weeks to reach that therapeutic range. So educate patients when saying this med is not working after the first week, or they're also saying something about sexual dysfunction. Patients need to know about this first so they won't stop taking the drug. Now, third is we never mix these key words here. SSRIs with St. John's wort and MAOIs with any other antidepressants. We're talking TCAs, SSRIs, even SNRIs. Guys, this could lead to deadly serotonin syndrome. So, 2-week washout period is needed. Guys, keyword there, 2 weeks. Write that down. Keywords: never start a new antidepressant while tapering off an MAOI or another. So, just coming off the day before is a big no-no. Always a taper off and never mix. Now, point number 4 is all psychiatric drugs usually decrease the blood pressure, so we teach slow position changes for risk for falling, and causes weight changes, mostly weight gain. Now, first up are the SSRIs, sertraline, citalopram, and escitalopram. Guys, those came up the most often on all the quiz banks. But we also have paroxetine and fluoxetine. Now, SSRIs are given mainly for depression, anxiety, and PTSD. Now, the mode of action is quite simple. Typically not tested on the NCLEX, but it could come up on pharmacology exams. So guys, just let the name help you. For SSRIs, selective serotonin reuptake inhibitors. Basically inhibits the reuptake of serotonin, keeping more around. So serotonin levels are increased in the body. Now, the 4 common side effects, which usually improve after 3 months. Number 1 is weight gain. Number 2, which is a big one, sexual side effects. The key point, and always on the NCLEX, write this down. Sexual dysfunction. So just remember, sertraline causes sexual dysfunction. And there's no sedation. So don't be tricked. SSRIs usually cause insomnia. Now, priority key points. We use the acronym SSRI. S for the suicide risk that is increased when starting the med or changing the dose. Again, high risk is age 18 to 24. And a key priority to monitor, big key point right here, report more energy without change in depression. Guys, huge risk for suicide. Now, the second S is for a slow onset and a slow taper off, usually taking about 2 to 4 weeks to reach that full effect. So we teach patients not to stop the med when starting and during this time. And guys, always taper off, never abruptly stop. Now, the next S is for serotonin syndrome, a very deadly complication which happens if we use drugs or vitamins that also increase serotonin levels. Guys, we're talking about a serotonin overdose. So the big key point here is we never mix, write this down, St. John's wort, MAOIs, or tramadol, never to be mixed with SSRIs. Now, the signs and symptoms include SRI. S for sweaty, hot fever, never cold or clammy. We're talking really hot here. R for rigid muscles, restlessness, and agitation. Guys, big key words. Write those down. We're talking tremors and hyperreflexia, not decreased DTRs. They'll actually be increased. And speaking of increased, I is for increased heart rates, known as tachycardia, over 100 beats per minute. Now, the famous SNRI, duloxetine, given for depression and pain, like with neuropathy and fibromyalgia. So guys, just think duloxetine is for a dual purpose, both depression and pain. Or duloxetine helps to dull the pain with fibromyalgia. Guys, the big key point here is to teach that it helps with chronic pain, and it also improves sleep in patients with fibromyalgia. Now, don't be tricked. Common test questions is a client refusing this medication. So, patients can always refuse medications. That's not the problem here. But the most appropriate response is to educate the patient on why the medication is given, basically the indication. So, for example, if a fibromyalgia patient is prescribed this and they're not depressed, they need to be educated on the purpose of why this medication will help with the pain. Now, for our TCAs, tricyclic antidepressants, we have the 2 famous ones, amitriptyline and imipramine. So memory tricks here. Amitriptyline, just think Amy trips on things. So guys, we have slow position changes. And imipramine just basically inhibits my peeing. Now, the indication is for depression and anxiety. And it also helps with neuropathy or neuropathic pain with diabetes and fibromyalgia. But the common side effects to be written down here. The big dry, the anticholinergic effects, guys. Basically, can't see, pee, spit, or poop. You get the point. So can't see, we get blurred vision and photophobia. Can't pee, we get urinary retention. Guys, that's a big NCLEX tip. Priority and most serious. We also can't spit, so we get a dry mouth. And you can't poop, so you get constipation. Now, other side effects, we get sweating, seizures, and sedation, known as drowsiness or dizziness. So it's a priority to teach patients slow position changes. Now, speaking of patient teaching, we treat the dry by drinking the fluids. And for no seeing or dry eye, we teach them to wear sunglasses and eye drops. And no spit for dry mouth, chew the gum, and for no poop, guys, we use fiber for constipation. Now the big key points to write down again. Orthostatic hypotension, we teach slow position changes because amitriptyline, just think Amy trips on things, guys, slow position changes. And urinary retention, again, the memory trick, imipramine inhibits my peeing. And lastly, we never take with an MAOI. Always a 2-week washout period. So remember, no MAOIs and other antidepressants. We're talking TCAs, SSRIs, even SNRIs. So remember, MAOIs do not mix well with others. Not even a tapered down dose. You must fully come off MAOIs first before transitioning to another antidepressant like a TCA or even SSRI. Now for the MAOIs, always an NCLEX favorite here. We have phenelzine, brand name Nardil, selegiline, and isocarboxyside. These are the first and oldest antidepressants, known as the big guns. Very powerful antidepressants used for depression, panic disorder, as well as social phobia. Now the mechanism of action is that it increases availability of norepinephrine, serotonin, and dopamine in the brain. And it's used for depression that is resistant to other medications. So the key points for MAOIs is just the acronym MAOI. M for massive hypertension crisis risk. Usually a key sign is a massive headache. So we avoid the tyramine. Now that's an amino acid that helps regulate the blood pressure and actually triggers hypertension crisis, leading to death from a heart attack like an MI or a CVA stroke. So guys, the big no-no list to avoid. So no fermented alcohol, fermented fruits or veggies, and even meats. So number 1, wine and cheese. Guys, no, so no wine tasting. Number 2, beer and sausage and salami, no beer fests. And number 3 is chocolates. Guys, no visiting Charlie or his chocolate factory. We are teaching patients to start the diet at least 2 weeks before starting MAOIs and continue for 2 weeks after stopping. So the memory trick is tyramine, ends in INE, like phenelzine. Just think tyramine, or selegiline is tyramine. So no cheese, beer, sausage, or wine for tyramine. So big questions on the exams here. Can the patient eat fruit? Guys, yes. Can they eat veggies? Yes. Can they have fermented fruits or veggies, or even pickled veggies? No. Dried processed fruits? No. What about liver, tongue, sausage? Guys, these are all meats, so no, they cannot have it. Now, O is for OTC, or over-the-counter drugs. And this could contribute to a hypertension crisis. So guys, we avoid can. C for calcium, A for antacids, A for acetaminophen, or basically Tylenol, and N for NSAIDs like naproxen and ibuprofen. Now our next O is for other antidepressants to avoid. Guys, remember, MAOIs do not mix with other antidepressants. So we're avoiding TCAs, SSRIs, SNRIs. This can actually trigger a serotonin syndrome. So we have a 2-week washout period when changing or swapping out antidepressants. Guys, 2 full weeks, not 2 days, not the day before, 2 weeks from the ending. Keyword is fully taper off the other. So the big key point is no escitalopram, which is an SSRI, and no imipramine, which is a TCA. Guys, the NCLEX will try and trick you, so just make sure to know the names of these drugs. Now, I is for increased suicide risk, usually within the first few weeks of treatment or when the dose is increased. Now, this especially happens in children, adolescents, and young adults. So the key words to write down here, guys. Patient states this med is not working after 2 weeks. The first thing to do is assessment, guys. So further expressions of hopelessness, despair, or suicidal thoughts or harming themselves usually indicates a reason to report to the HCP. Now for the top 3 missed questions of psychiatric meds. Which medication has the most potential risk for injury? Select all that apply. Guys, we're looking for sedating meds here. So number 1, amitriptyline. Remember, Amy trips on things. Very sedating, so yes. Option 2, diphenhydramine or Benadryl. Yes, guys, very sedating. High risk for injury. How about option 3, Colace? No, that's technically a stool softener. No sedation there. Option 4, alprazolam. Yes, guys, that's a benzo, Pam and Lam. Very dangerous life. And option 5, buspirone. No, remember bus. You can drive the bus. It's not sedating. Now, question 2, which combination of drugs should the nurse question? Select all that apply. Guys, the main focus here is we don't want to mix between SSRIs and MAOIs. Because remember, MAOIs don't mix with others. So option 1, sertraline with selegiline. Guys, that's a big no-no. That's an SSRI and MAOI. Never mixed. Option 2, alprazolam with citalopram. So benzos and SSRIs, that's okay. Now third, buspirone with phenelzine. That's an anxiolytic with an MAOI. Technically okay. Now how about lithium with ketorolac, or brand name Toradol? That's a tricky one since lithium is a bipolar med and ketorolac is an NSAID. So guys, that's a big no-no. And option 5, St. John's wort with buspirone. Technically that is okay. Now question number 3, which has the most potential for injury? Select all that apply. So option 1, amitriptyline to treat fibromyalgia pain. Guys, yes, Amy trips on things. It's very sedative. High risk for injury. Now option 2, a headache while on phenelzine. Guys, yes, the very first sign of a hypertension crisis is a headache. Huge risk for CVA stroke. Now option 3, taking St. John's wort with sertraline. Guys, yes, sertraline is an SSRI. And St. John's wort we have to stop. Guys, nothing really comes good from St. John's wort. Now option 4, discontinuing escitalopram the day before isocarboxamide. Guys, no, that's the most injury. Guys, we can't mix an SSRI and an MAOI within 2-week period of each other. So not the day before. Has to be 2 weeks totally separated. Now option 5, a peanut butter and jelly sandwich while on selegiline. Guys, this is okay. Alcohol, cheese, and meats are okay. No tyramine in it for this MAOI. Now, if it was a grilled cheese, that's a big no-no. Or a ham sandwich has meat in it, big no-no. And even beer and sausage, we have no alcohol, guys. So no alcohol, cheese, or meats. Now, option number 6, reporting sore throat, fatigue, and low-grade fever while on clozapine or clozapine. Now, this technically isn't fair because this is an antipsychotic drug. But guys, yes, clozapine zaps WBCs, making a huge risk for infection and technically a risk for injury. Now we have 2 atypical antidepressants, trazodone and bupropion. So for trazodone, the indication is for a sleep aid and treats depression. So memory trick is the Z's in trazodone, which makes you sleepy and sedated. Or think of transidone, it basically puts you in a trance. Now the key is to avoid ETOH and other sedatives, such as benzos and antihistamines. And we teach the patient to take at night. Since it can cause orthostatic hypotension, we also teach slow position changes. And a very rare complication is a priapism. So teach a patient that if an erection lasts longer than 4 hours, to go to the hospital. Now next is bupropion SR or XL. Brand name is Wellbutrin. The indication is for depression and an aid to stop smoking. Now the side effects is insomnia, headache, and weight loss, which is probably not a bad side effect. Now teaching, guys, we never double up on missed doses, just like any other medication. And nicotine gum may be prescribed in addition to help stop smoking. Now administration, guys, the big key point here is XL and SR, or basically extended release and sustained release. We never crush, never chew, or cut these kinds of drugs. So meds labeled SR or XL should never be altered before admin. Always swallow whole with or without food.
Guys, if you chew or crush, it could cause faster absorption and higher levels of the drug can be increased. Hence, the side effects will increase as well.